Well, welcome back from your break. Let's go on to case 4. Chief complaint, both my legs hurt. The patient is a 65-year-old man who developed severe leg pain that comes on after walking about 4 city blocks. His exercise tolerance has some variability. However, the patient initially noted problems while walking downhill with the onset of numbness and weakness in the legs. The patient had taken to sitting at bus stops, waiting for the pain to resolve, and then walking to the next bus stop where he would again stop for a rest. The patient initially had symptoms in his left leg that later spread to his right leg. The numbness and tingling increases as he walks. The patient recalls only mild low back pain that he has had for a number of years, no change in bowel, bladder, or sexual function. So basically, we have a 65-year-old man who's coming to the doctor complaining of exertional leg pain. When he walks, he gets pain. He stops, and the pain goes away. So what are the 2 major diagnoses that you always have to consider when a patient complains of exertional leg pain? The 2 diagnoses are spinal stenosis, otherwise known as pseudoclaudication, or peripheral vascular disease, or real claudication. Now, how do you differentiate pseudoclaudication or spinal stenosis from real claudication or angina of the lower extremities? Now, real claudication is essentially angina of the lower extremities. As the oxygen requirement and therefore the blood supply demand increases with activity, and there is a blockage in the artery supplying those muscles or supplying that extremity, the patient gets pain or angina in his calf muscle or in his leg muscles. Pseudoclaudication looks like real claudication. Why? Because the patient will get his pain on exertion. And sometimes it can be very, very, very difficult to differentiate between pseudoclaudication and real claudication secondary to peripheral vascular disease. So what on the history will point you towards peripheral vascular disease versus spinal stenosis? So when we talk about vascular disease in general, we talk about atherosclerosis. And on the boards, if they want you to be thinking about peripheral vascular disease, or they want you to be thinking about coronary artery disease, or they want you to be thinking about cerebrovascular disease, they will give you a story with the risk factors consistent with atherosclerotic disease. So if we look back at our case, they don't mention smoking. They don't mention diabetes. They don't mention hypercholesterolemia. They don't mention hypertension. The emphasis and the focus in the history is not on atherosclerotic disease. The only thing consistent with peripheral vascular disease is the exertional nature of the symptoms. Other than that, the question writer is not pointing you towards atherosclerosis, because he's not mentioning risk factors for atherosclerosis. Secondly, when the case history mentions no change in bowel, bladder, or sexual function, that's important because he has low back pain. And we want to know if he has spinal cord compression causing his weakness. And if we don't have change in bowel, bladder, or sexual function, if we remember back to our case of the lady with breast cancer, those are clinical signs in the history that he doesn't have spinal cord compression, but may have spinal stenosis. So again, the fact that there's no risk factors for atherosclerotic disease implies that it's not peripheral vascular disease. If they told you that this was a 65-year-old man who developed severe leg pain, and he has a history of diabetes, and a history of hypertension, and a history of high cholesterol, and a history of smoking, and he's had 2 MRIs in the past, and a stroke, then you should be thinking about peripheral vascular disease. but they're not telling you that, which steers you away from that diagnosis. How on physical exam do we differentiate between peripheral vascular disease and spinal stenosis? You look for evidence. You look for evidence of nerve impingement or evidence of a neurologic deficit associated with the spinal stenosis. If you think about peripheral vascular disease will not give you hyperreflexia, will not give you weakness, will not give you sensory loss associated with spinal stenosis. Spinal stenosis is essentially a neurologic disease that will give you neurologic findings on physical exam. Peripheral vascular disease generally will not give you hyperreflexia, will not give you increased tone, will not give you focal neurologic weakness, but rather will give you loss of hair, gangrene, and so on. So based on the history and based on the physical exam, you can differentiate the two. So when we go to our physical examination, the patient was found on the examining table with hips and knees flexed. When the reflexes were tested in the recumbent position, the reflexes were absent. With the patient sitting up and stooped forward, all reflexes were present in the lower extremities. So here you have a focal neurologic deficit. You have a deficit where the reflexes are lost consistent with a peripheral neuropathy. And he has some sensory loss below the knees, which was mildly diminished. So the differential diagnosis is a lumbar spinal stenosis. And why are we thinking spinal stenosis more than peripheral vascular disease? Because there are no risk factors for atherosclerosis given in the history. And claudication from peripheral vascular disease is also our main differential diagnosis. So how do we look for spinal stenosis? The best initial diagnostic plan is to exclude peripheral vascular disease. And we can do that by measuring an ankle brachial blood pressure ratio and by measuring the peripheral pulses. And if the results by the ankle brachial pressure ratio are normal or greater than 1, we've excluded peripheral vascular disease, and we must think about spinal stenosis. Now, what is the most sensitive test for the diagnosis of spinal stenosis? The answer is MRI. The most sensitive test for spinal stenosis is MRI. And how do we treat? We treat with rest, anti-inflammatory medications, surgical decompression at the level of the stenosis with laminectomy. So when you get the MRI on this particular patient, you get the result of a narrow lumbar canal with osteophytes, spurs, and hypertrophy of the ligamentum flavum, all consistent with spinal stenosis. So the final diagnosis is lumbar spinal stenosis. You make that diagnosis by ruling out peripheral vascular disease. MRI is your best or most sensitive test, and treatment is decompression with surgery, anti-inflammatory medication, and rest. Let's go on to the next case. Case 5. Chief complaint. My hand is weak and I can't talk right. The patient is a 55-year-old black man with a history of high blood pressure, non-insulin dependent diabetes mellitus, and hypercholesterolemia. So just from the first line of the case, we see that the question writer is emphasizing risk factors for atherosclerotic disease. He's telling you the patient has diabetes. He's telling you the patient has hypercholesterolemia. He's telling you the patient has high blood pressure. And that this patient did not like doctors much, but recently had come under the care of a medical doctor for control of his blood pressure and diabetes. Now, 2 weeks earlier, the patient had an episode of loss of vision in the left eye that resolved after hours. Now, what's that? That is a TIA. And in fact, patients who have TIAs, immediately after their transient ischemic attack, have a higher risk of having a full-blown CVA. And this is a patient who 2 weeks ago had a TIA with a loss of vision in the left eye that resolved after a number of hours. That's sort of a warning sign that he was at high risk for having a full-blown CVA. Now, his wife recounts garbled speech and right hand weakness for 1 day prior to his arrival in the emergency room. The problem developed suddenly. So here we have a patient who's complaining of acute onset of right hand weakness, some sort of inability to talk, which is generally called an aphasia, that is of acute onset. With risk factors for atherosclerotic disease. The most likely diagnosis is acute cerebrovascular accident, or CVA, or stroke. Now, when you're dealing with patients with CVA, it's very, very important to make the distinction between hemorrhagic stroke and to make the distinction between ischemic stroke. Because hemorrhagic stroke will be managed very, very differently than an ischemic stroke. So when a patient comes in with risk factors for atherosclerosis and risk factors for cerebrovascular disease with an acute onset of a focal neurologic deficit, the next step in the management of this patient is to get a CT scan of the head. Now, why are you getting a CT scan of the head? You are getting a CT scan of the head to differentiate between hemorrhagic stroke and ischemic stroke. And because you want to make that differentiation, the CT scan of the head initially will be done without IV contrast. Because you want to see if there is blood in the brain or no blood in the brain. And CT scan is the most sensitive test to determine bleeding in the brain. It is more sensitive than MRI. So when this patient comes into the hospital and says, I have focal weakness, risk factors for atherosclerotic disease, and it was of sudden onset, the best initial test is CT scan without IV contrast to differentiate between ischemic stroke and hemorrhagic stroke. And when you do the CT scan without IV contrast, you're not looking for an ischemic stroke per se, because sometimes ischemic strokes don't show up on the CT scan for 48 to 72 hours. But rather you are looking for the absence of blood. Because once you have determined that there is no intracranial hemorrhage in a patient with an acute onset of focal neurologic deficit and risk factors for cerebrovascular disease, you assume that it is an ischemic stroke and you treat it appropriately. Now, how do we treat ischemic stroke? Well, there are a number of medications that we can give patients with ischemic stroke. One is aspirin. Every patient who comes in with a focal neurologic deficit, negative CT scan of the head without IV contrast, and risk factors for CVA should get aspirin. The other medication we use is heparin. Heparin is only indicated in acute CVA for patients who have atrial fibrillation and a CVA, or who have cerebrovascular accidents in evolution, or stroke in evolution. Now, what do I mean by stroke in evolution? I mean that a patient comes in with a neurologic deficit, and when you check on the patient in a half an hour, the deficit is worse or more dense. And then an hour later, it becomes worse or expands. So if the neurologic deficit is not stable, but is worsening quickly over time, then we assume that the stroke is secondary to some thrombosis, intra-arterial thrombosis, and we treat with heparin. So unlike acute myocardial infarction, where every patient who comes in with an acute MI or a suspicion of an acute MI will get heparin or low molecular weight heparin. In CVA, there are specific indications. And those are CVA in the context of atrial fibrillation or intracardiac thrombus, or stroke in evolution, where you would give heparin when the focal neurologic deficit is worsening quickly over time. The third medication we give is TPA for ischemic stroke. Now, what are the indications for giving TPA in ischemic stroke? It's very simple. Patients who come in, who present to the emergency room with ischemic CVA, and who present within 3 hours of onset of their neurologic deficit are candidates for TPA therapy. Now, that means that patients have to document, or it has to be very, very clear, that the neurologic deficit began no more than 3 hours ago. So, for example, if on the boards you get a patient who went to bed the previous night at 11 p.m., woke up at 7 a.m. with a neurologic deficit, comes to the emergency room at 8 a.m., that patient does not get TPA. Do not consider the stroke, do not consider that the stroke began at 7 o'clock in the morning, because the stroke may have occurred at 11:01 or 12:01 the night before or 4:01 in the morning, and he's only noticing the neurologic deficit at 7 o'clock. So we're very, very strict about defining this 3-hour window. And in that particular case, because we can't clearly define when the neurologic deficit began, we do not give such a patient TPA. So again, patients who come in with aspirin, who come in with the CVA and it is ischemic, we give them aspirin. We give them heparin only if there is a thrombus or atrial fibrillation or they have stroke in progression. We give them TPA if the neurologic deficit started and they present to the emergency room within 3 hours. Now, are there any contraindications to TPA therapy? The answer is yes, there are contraindications to TPA therapy. And we have to consider those contraindications before we give TPA. These contraindications that we're going to mention here for CVA in terms of TPA therapy apply to acute myocardial infarction. And you have to know these contraindications. Absolute contraindications are ischemic stroke within 1 year. Meaning if a patient comes to the hospital, even if they come within 3 hours, if they've had an ischemic CVA within the last year, they cannot get TPA. If they have ever had an intracranial bleed or a hemorrhagic CVA in their lifetime, they cannot get TPA. If they have a coagulopathy, they are on warfarin, or they are on low molecular weight heparin, then they cannot get TPA. Patients who have a history of brain tumor or intracranial lesion cannot get TPA. Surgery within 2 weeks is also a contraindication to TPA therapy. So when you decide to give TPA for acute ischemic stroke, you have to make sure there are no contraindications to the therapy. Also, patients who have uncontrolled blood pressure cannot get TPA, or it's a relative contraindication to the use of TPA in acute stroke. Now, how do we work up patients with acute CVA? Well, we ask ourselves, first of all, we'd like to localize the stroke clinically, because that will determine how we work up the stroke. How do we localize the stroke clinically? Well, the blood supply to the brain is distributed generally into the anterior circulation, which is supplied by the carotid arteries, or the posterior circulation, which is supplied by the basilar arteries or the vertebral arteries. The anterior circulation, large vessel disease, is divided into the anterior cerebral artery and the middle cerebral artery. Now, what is characteristic of middle cerebral artery infarcts? Patients who have weakness in the face and the arm, more than the leg, have MCA infarcts, or middle cerebral artery infarcts. Patients who have weakness more in the leg than in the arm and the upper, and then in the arm and the face, have anterior cerebral artery infarcts. A mnemonic that I like to use is that you always like to put your best foot forward. So when you're dealing with the forward stroke or the anterior cerebral artery, you have weakness in your lower extremity greater than weakness in your upper extremity. Posterior circulation usually gives you cross syndromes. Things like Weber's syndrome, which is cranial nerve palsy, let's say, on the left side with a right hemiparesis. You have a palsy on the one side with a hemiparesis on the other side. The syndrome is crossed. Benedict syndrome is cranial nerve palsy on the left side with ataxia on the right side. It is a cross syndrome. Patients with posterior circulation and who have CVAs can present with vertigo, can present with syncope. And these are all signs of posterior circulation. Visual hallucinations if they have posterior cerebral artery large vessel disease. Now, lacunar infarcts generally are purely motor, purely sensory, and you have a specific syndrome associated with dysarthria and upper extremity weakness. Those are lacunar infarcts, not large vessel disease, rather disease of the small penetrating vessel. And that is, in fact, the most common stroke are the lacunar infarcts, especially in patients with diabetes and so on. So, when we localize a disease, we like to try to find out what vessel is involved if it's large vessel disease. And if it doesn't fall into any of these large vessel syndromes, we consider it to be a lacunar infarct and to prove another one. So how do we work up acute CVA? If we have large vessel disease, we always want to consider embolic phenomena. And where do emboli come from if there is anterior circulation disease? It comes from the carotid or it comes from the heart. And how do we work up thrombus in the heart? We get an echocardiogram. We get an EKG to look for atrial fibrillation. Now, if the EKG, when the patient comes into the emergency room, is negative, do we stop there? The answer is no, because patients can have paroxysmal atrial fibrillation, meaning they're in and out of sinus rhythm and atrial fibrillation. And when we take the EKG in the emergency room, we may be getting them when they're in sinus rhythm. So if there is a suspicion of embolic phenomena, we also get a 24-hour Holter monitor to look for episodes of atrial fibrillation. We get the echocardiogram. We get the carotid duplex if the patient has anterior circulation CVA, i.e. a CVA associated with lower extremity weakness greater than upper extremity. That would be the anterior cerebral artery, or the middle cerebral artery, which is upper extremity weakness and facial palsy more than lower extremity. Echocardiogram, EKG, carotid duplex and anterior circulation, strokes, and the 24-hour Holter monitor to look for atrial fibrillation. So a physical examination, this gentleman's speech is fluent, but he has frequent errors. For example, he has thumb for tongue, unable to repeat the phrase, "Today is a nice day." Now, he obviously has an aphasia. Now, aphasias are dominant hemisphere signs. Patients who have strokes of the dominant hemisphere will have an aphasia. There are two basic types of aphasia. There is Broca's aphasia and Wernicke's aphasia. Broca's aphasia is broken. The patient understands speech, but has difficulty with the mechanics of speaking. Wernicke's aphasia is wordy. The patient has no mechanical problem expressing himself, but doesn't understand or does not converse appropriately. So this gentleman has fluent speech, which means mechanically he's able to speak. But he makes errors, he confuses words, and he's unable to repeat phrases. That's consistent with wordy speech that is mechanically intact, but the understanding is not there. Broca's is the opposite, where the mechanical function or the mechanical functioning of the ability of the patient to speak is compromised, but he understands what is being said to him. So aphasia is a dominant hemisphere sign. Now, non-dominant hemisphere signs are things like neglect, visuospatial defects. Patients would not be able to identify common objects in their hand. If you would write letters on their palm, they would not be able to identify those letters. Those are non-dominant hemisphere signs. So this gentleman has an aphasia. So we can say from that he has a dominant hemisphere stroke. He has pronator drift, which is a sign of weakness of the upper extremity, and increased tone, which is again an upper motor neuron sign. His reflexes were brisk on the right, and he had a Babinski sign on the right. So the differential diagnosis is stroke due to bleed, secondary to hypertension, which is hemorrhagic stroke, ischemic stroke or bland infarction of the MCA. Okay? Whether it's thrombotic or embolic, we work up and we look for. We do the echocardiogram, we do the Holter monitor, and the best initial diagnostic test is CT of the head without contrast to differentiate between hemorrhagic and ischemic stroke. And only once we've made that differentiation can we appropriately manage this patient. Now, let's say this gentleman came in and he was complaining of right arm weakness. And you go ahead and you do the carotid duplex because he has anterior circulation signs. And you find on the carotid duplex that he has an 85% occlusion of his right internal carotid artery and only a 30% occlusion of his left. Would you send this patient for carotid endarterectomy? The answer is no. Why? Because the indication for carotid endarterectomy is symptomatic occlusions greater than 70%. And if you think very carefully about the scenario that I gave you, where he has an occlusion greater than 70% on the right side, and his weakness is on the right side, when you have an occlusion of greater, for this occlusion to be symptomatic, he would have to have left side weakness, which he does not have. He has right sided weakness. So don't be tricked by the ipsilateral weakness with the ipsilateral occlusion greater than 70%. So the only clear indication for carotid endarterectomy is symptomatic occlusion greater than 70%. In patients who have asymptomatic disease, they only go for carotid endarterectomy when they have high-grade stenosis greater than 90%, when that stenosis is bilateral, and when the patient is a good surgical risk. When the patient is a good surgical risk. On the boards, the indication for carotid endarterectomy is symptomatic lesions greater than 70% in the internal carotid. Everything else is controversial. Now, let's say this gentleman came in. He's 54 years old. He's having an acute CVA, and he was on aspirin, and he was taking his aspirin, and he has a CVA on aspirin. What is a medication that you would add to this patient's regimen? The answer is that you would add clopidogrel. And why do you add clopidogrel? Because this patient is a patient who had a CVA on his aspirin. He has failed his antiplatelet therapy. When patients have failed their antiplatelet therapy, you have to expand that antiplatelet therapy, and you have to add clopidogrel, or you have to replace the aspirin with clopidogrel. So when patients stroke on aspirin, they have failed their aspirin therapy, and their antiplatelet therapy has to be expanded with clopidogrel. Now, why do we not use taclopidine? The answer is that the side effect profile for taclopidine is much worse than that of clopidogrel. And what's the classic side effect of taclopidine? There are two: neutropenia and hemolytic uremic syndrome, or HUS or TTP. So taclopidine we don't use anymore because it gives us a lot higher rate of TTP and HUS and a lot higher rate of neutropenia. We use clopidogrel, which can give us these side effects, but does it much less frequently. So when patients fail their aspirin therapy, you have to add enhanced antiplatelet therapy with clopidogrel. When do you use clopidogrel in addition to this indication that I mentioned? When patients have an allergy to aspirin, or patients have had significant GI bleeds on aspirin, which is an NSAID. So patients who have an allergy, who cannot tolerate the medication, or fail antiplatelet therapy with this medication, you add the clopidogrel. It's sort of like patients who are on Coumadin for DVT and have an additional DVT on Coumadin, that you have to expand your treatment by giving them a filter or some other treatment. So the same concept applies here. So again, in summary, when patients come with an acute focal neurologic deficit and there is a history of risk factors consistent with atherosclerotic disease, you have to think about CVA. And when you think about CVA, the best initial test is a CT without IV contrast of the head to differentiate between hemorrhagic and ischemic stroke. Ischemic stroke is treated medically with aspirin. If patients have a CVA on aspirin, Plavix or clopidogrel has to be added to the regimen. Heparin, if there is atrial fibrillation, either on the 24-hour Holter monitor or the EKG taken when they came into the ER, or there is thrombus on echocardiogram. And TPA, if the patient presents within 3 hours and there are no contraindications to the treatment of TPA or to the giving of TPA in these patients. We localize the workup consists of looking for an embolic source, which is why we do the 24-hour Holter, which is why we do the echocardiogram, which is why we do the carotid duplex. Indications for carotid endarterectomy are symptomatic lesions greater than 70%. Let's move on to the next case. So in this particular case, after we did the 24-hour Holter, we found atrial fibrillation, and the patient gets Coumadin for the rest of his life. Now, in terms of risk factor management, if on the boards they ask you a question, what is the single most important risk factor to control for cerebral vascular disease in terms of the risk of stroke? The answer is not smoking. The answer is not hyperlipidemia, but the answer is hypertension. So for CVA, if you were going to control only one risk factor in terms of primary prevention or secondary prevention, you will control this patient's hypertension. Okay, let's take a break, and we'll come back with the next case.